good morning or good afternoon, depending on where you are. Thank you so much for joining me today. And I guess I'll just move right along into the first slide, which is, of course, the disclosure to say that I work for Pearson. I'm an employee of Pearson, and the assessment instruments that I'm going to mention during the presentation are those that Pearson publishes. So matching the description, I'm going to cover a little bit of information about the current state of healthcare in the United States, healthcare/mental health care, talk about the biopsychosocial factors in healthcare, and then some considerations when selecting instruments for assessment in the healthcare environment, and then give some examples of instruments towards the end. As Sherry mentioned, the handout went out in an email to you, the reminder email at the top of the hour, and it has all of the slides in it. Before I begin, I would like very much for you to respond to this poll question, please. Do you currently use health psychology tools in your practice today? And, when thinking about how you define those, you can define those. So an instrument that you would consider a useful health psychology or health assessment instrument. I'll give you a minute to do that, and then we'll jump right in. Okay, we don't have near as many answers yet as we do participants, so I'm going to give you just a little bit longer. If you don't mind, please respond either yes or no. Just gives me some idea of whether or not people are currently using assessment tools in their practice, tools that they would consider useful for health assessment. Okay. Getting more of you do than don't, but at this point there's a good many of you that are not using health assessment tools. So I'm going to go on and jump in. We're going to talk first about healthcare and some of the biopsychosocial factors in healthcare. Because of some public health successes in the first half of the 20th century, things like treating infectious and contagious diseases such as tuberculosis and flu, and then in the last half of the century with medical and surgical interventions that address care in response to acute things like heart attack and stroke, the U.S. population is living longer, and that leaves us with new challenges in the 21st century, namely addressing the chronic conditions of an aging population. You see that nearly half of the U.S. population live with at least one chronic condition. Chronic conditions are considered to be illnesses and impairments that limit daily functioning, are expected to last a year, at least a year, and require ongoing medical care. There are things like diabetes and hypertension and congestive heart failure and cardiovascular disease, and they rarely occur in isolation. They often occur along with other chronic diseases. You see that in 2009, 21% of Americans ages 45 to 64 and 45% of Americans older than age 65 had two or more coexisting conditions. Chronic diseases and conditions like heart disease and stroke and cancer and type 2 diabetes, obesity, and arthritis, those are among the most common, the most costly, but also preventable of all health problems. And they're surprisingly common. As of 2012, in the United States, about half of all adults, or 117 million people, had one or more chronic health conditions. 1 in 4 adults had 2 or more chronic health conditions. 7 of the top 10 causes of death in 2014 were those chronic diseases, and 2 of those, heart disease and cancer, together accounted for nearly 46% of all deaths. That's really a surprising and huge number of people who suffer from chronic medical conditions. It's important to recognize that psychological conditions play a role in primary care beyond the mere perception of symptoms or compliance with treatment. Of the 15 leading causes of death, and here you see the top 10, 13 are known to be related to behavior and lifestyle factors, so things like diet and exercise and tobacco use. For those 13 causes of death, psychological interventions to manage behavioral risk factors are a primary means of prevention. This slide depicts the number of visits to family physicians by diagnosis code. Data suggests that injury and disease seen in primary care generally appears in the form of illness in a combination of distress and disease or suffering, which is a combination of distress and pain. And research has found that the inclusion of psychological services in primary care can lead to reductions in the number of medical visits by 30 to 40% and reductions in medical costs by 20 to 40%. And it's been pointed out that if there were a new medical procedure that were supported, hold on. I'm sorry, the oak pollen is driving everybody here in Texas crazy. I apologize. I was saying, it's been pointed out that if there were a new medical procedure that were supported by evidence that is as strong as the evidence for psychosocial interventions for medical patients, it would be readily accepted immediately. Older 20-year longitudinal studies, or there was an older 20-year longitudinal study, that examined patient visits at a very large HMO. And the results of the study that found that over the 20-year period, for 60% of all visits in primary care, no identifiable organic causality was found. And this was interpreted as suggesting that reasons other than objective medical conditions were likely to bring people in to see their physician. There was a later replication of the study that found that that was 70%. And for the most part, these patients did not perceive themselves as having a psychological condition. In a more recent study, 58% of patients that presented in primary care were diagnosed as having some type of DSM-4 somatoform condition, with the most common conditions being NOS, or somatoform disorder NOS, and undifferentiated somatoform disorder. But that really suggests that a large percentage of patients come to primary care with complaints that are not relatable to diagnosable illness or pathophysiology, but rather with symptoms that are associated with stress and psychiatric conditions. The prevalence of psychological conditions within the medical setting really does create a dilemma for physicians. There's been some research that's found that physicians spend on average only about 10 minutes with patients. And of course that's divided between taking a history, reviewing medical test findings, and then examining the patient. And if they don't find objective medical findings, if they're not revealed then, that there's really almost no time left for exploring psychological variables. So it's not really surprising that researchers found that psychological disorders in primary care are overlooked a large percentage of the time. Center for Medicare and Medicaid Services data indicate that as of May 2014, about 510,000 people identified themselves as behavioral and social science providers. About 16% of them were psychologists. This data was obtained from the National Provider Identifier Database, the NPI database, where about 78% of licensed psychologists are registered. There's obviously more behavioral health providers that are not necessarily registered with NPI, although if they're billing, they are. The Center for Medicare and Medicaid Services in the last several years has awarded both the American Psychological Association and the American Psychiatric Association monies with which they've begun specific programs to train mental health providers to work in primary care settings as a result of evidence that integrating behavioral health into primary care does reduce costs and improve population health. And so those monies are for training psychiatrists, psychologists, and social workers. And then there are other programs that are beginning to more broadly train mental health providers, behavioral health providers to work in primary care. Behavioral health in medical settings has been implemented in several different models, but the overall idea is for behavioral health providers to collaborate with primary care providers to assist with patient care. Patients are sometimes referred when either the patient hasn't been compliant with the medical treatment program or the treatment hasn't really succeeded to the level that the doctor had anticipated. Physicians sometimes will often refer patients for psych evals when the case is more complex or there's comorbidities present. But physicians and psychologists really look at their patients differently. The psychologists and physicians focus on different aspects of patient care. when they work together, then they can focus on the whole patient, which enables them to really develop a treatment plan that's more specific to the needs of the patient, of course, improving medical care and outcomes as a result. Often there are treatments available for a particular medical disorder, and from the psychologist's perspective, rather than take a hit or miss approach, the behavioral health provider will use psychological assessment to help identify characteristics of the patient's personality, and then in turn help determine the treatment method that makes the most sense for that particular patient. Just as an example, a change in diet may be a treatment recommendation, but if the psychologist discovers that the patient has a history of an eating disorder, the psychologist or the behavioral health provider is going to recommend a treatment that works around and with the patient's eating rather than working against it. So the behavioral health provider really kind of is charged with evaluating biopsychosocial findings related to physical health or illness, injury, disability, assessing biopsychosocial and behavioral risk factors for the development of physical illness, injury, or disability, and then designing and evaluating empirically supported health promotion, prevention, and other interventions that are appropriate to the patient. The American Psychological Association data on behavioral health in the United States points out that mental illness is associated with increased occurrence of chronic disease, lower use of medical care, reduced adherence to treatment therapies for chronic diseases, and higher risks of adverse health outcomes. Nearly half of those with any mental health disorder meet criteria for 2 or more disorders, and the severity then is strongly related to comorbidity. And over 8.9 million people have co-occurring disorders. And as you see, mental health disorders were one of the 5 most costly conditions in the United States in 2006. Sorry, there's a typo. With expenditures at $57.5 billion, which is just an astronomical amount of money for, caused by mental health disorders. Some information still from APA on access to treatment. You can see, just some of the different stats relating to access or lack of access. But up to 1 in 4 primary care patients suffer from depression, but only less than a third of those are identified. And you can see the last bullet there, people with psychotic disorders and bipolar disorder are 45% and 26% less likely to have a primary care doctor than those without mental disorders. So among the 8.9 million adults with any mental health disorder and a substance use disorder, only 44% received substance use treatment or mental health treatment in the past year. Only 13.5% received both mental health treatment and substance use treatment, and more than a quarter did not receive any treatment. So you can see the need for behavioral health clinicians. They really are an integral part of the primary care system, and we are working hard to increase their availability. Some information about depression. You probably know that major depressive disorder is the leading cause of disability in the U.S. for those ages 15 to 44. But major depression can develop at any age. The median age for onset is 32, but it affects approximately 14.8 million American adults, 6.7% of the U.S. population age 18 or older in any given year, and it's more prevalent in women than in men. And then anxiety, approximately 40 million American adults age 18 or older, about 18.1%, have anxiety disorder in any given year, and anxiety disorders frequently co-occur with depressive disorders or substance abuse. And nearly 3/4 of those with an anxiety disorder has their first episode by about age 21 and a half. There's some published studies that report that about 25% of all U.S. adults have a mental illness, and that nearly 50% of U.S. adults will develop at least one mental illness during their lifetime. There's some SAMHSA data, substance use data, that shows that mental and substance use disorders rank among the top 5 diagnoses associated with 30-day readmissions, accounting for about 1 in 5 of all Medicaid readmissions. You know that readmission rates or frequency is the topic of a lot of study at this time because of the cost to hospitals and hospital systems and insurance agencies, and that hospitals are often penalized now financially for frequent readmits. The Adverse Childhood Experiences Studies, which some of you are probably familiar with, they're a body of research that provide a clear set of findings that link difficult events, traumatic events, with an increased risk for chronic disease. These studies show that trauma in childhood increases risk for autoimmune and other chronic diseases and additional health problems later in life and even in future generations. This was a Kaiser CDC study with over 17,000 participants that were identified that identified this connection. But the results have been reproduced in other studies as well with different populations and a continuation of the original study with over 400,000 patients. So the key point really here from this body of research is that the effects of childhood trauma are not just psychological, but that they go on to that the effects last lifelong. Trauma alters brain development, function and structure, the autonomic nervous system regulation, physiology, stress response, and gene function. And you can see on the slide that that adverse childhood experiences increase risk for major causes of death. You can see a bunch of those on the slide. Just one more thing about that, and that's just that identifying and addressing trauma exposure offers us a framework, to provide effective care and outcomes, and it improves adherence to treatment and the use or overuse of services, really allowing us to make more appropriate referrals and connections to appropriate services and resources. Just as an example, using depression as an example, you've heard me say that it's one of the most common mental health problems, and it's also one of the most common complications of chronic illness. It's estimated that up to 1/3 of individuals with a serious medical condition experience symptoms of depression. The rate of depression among individuals who have had a heart attack, for example, is between 40% and 65%. And the U.S. Preventive Services Task Force found really convincing evidence that screening improved the accurate identification of adult patients with depression in primary care settings, and then they, in turn, recommend screening for depression in the general adult population and also recommend that screenings be implemented with adequate systems in place to ensure accurate diagnosis, effective treatment, and appropriate follow-up. So as you see here, the common association of mental and behavioral health conditions with these chronic medical disorders that I've talked about suggests that clinicians, as a matter of the normal course of treatment, should be screening for and assessing mental and behavioral health in these patients. And then once a decision has been made to treat, as I just mentioned, ongoing progress monitoring becomes really important to gauge whether or not the treatment is successful. It's also important that we use measures for both screening and more in-depth assessment that have strong psychometric data, that have reliability and validity established. And that's really critical in order to have confidence that these assessments are effectively measuring the target of interest. I'll talk a little more about that in a bit. And then efficiency of administration and scoring and interpretation are also all, of course, important given all of the demands that we have on us in healthcare settings. I'll talk some more about that in a minute also. So basically the important point there was that screening for depression, anxiety, substance use, other mental health conditions really should be a regular part of each visit along with monitoring the chronic conditions themselves. The notion of assessing the nuances of the medical patient's psychosocial characteristics really does have a long history. Understanding the whole patient, not just the disease that affects the patient, was a guiding principle of the physicians of the 19th century, people like Sir William Osler and Jacob Bigelow. Sir William Osler, who was an eminent 19th century clinician, said, "The good physician will treat the disease, but the great physician will treat the patient." So he introduced the idea of integrating as much information about the patient into treatment as possible. And then Dr. Jacob Bigelow defined the great physician as one who not only understands physical diagnosis, but also understands the patient who has that diagnosis. Not all patients with the same diagnosis are the same person. And that really suggests that medical outcomes can differ even with the same treatment. So despite a growing appreciation For the value of integrating information on the whole patient, in many cases, healthcare providers are still acquiring this information often only by using the physician's interviewing and communication skills. But we have behavioral health providers and tools for that. That is what we're trained to do, and we can help recognize potential problems before they interfere with the patient's response to and recovery from treatment. So in the 21st century, healthcare costs really constitute one of the greatest costs of being alive, and one that can be affected by patients as well as healthcare providers and the healthcare system. You see that medical diseases affect millions of lives, consume billions of dollars, as I mentioned earlier, and that healthcare costs for the management of chronic diseases are really considered to be just astronomical. But a substantial portion of healthcare costs are for treatment of conditions that have psychosocial sources. So clinical behavioral medicine interventions help reduce the frequency of medical utilization once we identify the patients that are most likely to benefit. So that's where we're going here. Some of the questions, these questions really boil down to what patient characteristics predict optimal medical outcomes and what predicts optimal response to therapeutic procedures, what psychosocial processes reduce the success of medical treatments. Are they psychiatric issues? Is it pain, outlook, personality, negative health behaviors? So what can we learn about our patients that would help us predict good medical outcomes and not so good outcomes? What patient characteristics actually bring people to see us in healthcare settings? What characteristics do they then bring with them into this setting? Which of these can work for or against the success of medical interventions like surgery? How can we quickly assess these characteristics in a reliable and valid manner? And how can we change those characteristics that are modifiable to better prepare the patient for surgery or other medical treatments? So in a model that represents an approach to identifying key psychosocial factors in health, behavioral medicine research has identified the links between psychosocial factors and primary prevention behaviors, so how people stay healthy, and between psychosocial factors and how patients respond to diagnosis and treatment of disease, so how they respond when they get sick and to their treatment, and then the link between psychosocial factors and how patients manage their chronic illness, how people manage long-term illness or adapt to the limitations from those. Research in medical economics and health sciences finds direct ties between a similar set of psychosocial factors and how people use the healthcare system, including utilization of healthcare services both under and over utilization, so ER visits, repeat visits, number of days hospitalized, and then also between psychosocial factors and treatment success and failure rates. So how psychosocial factors undermine or can undermine or facilitate successful treatments. This research really points to the attendant costs associated with these utilization patterns and clinical outcomes, which is a major but underappreciated driver of healthcare costs. We look at the links between psychosocial factors and health, for example, affective and psychiatric disorders, things like depression and anxiety conditions. These are often the outward signs that alert healthcare providers to the need for further assessment, which unfortunately many are not trained to conduct. These really can and do affect medical indicators and success rates. And then also cognitive appraisals, what patients think, their self-efficacy, optimism or pessimism, perceived control, so how patients perceive their health and their medical treatments, their coping strategies, what they do, what patients do, active coping, avoidance, denial. Together, cognitive appraisals and coping make up the patient's software, so to speak, for managing challenges. We also look at their resources, social, economic, familial, spiritual. The environment offers resources to managing these challenges, but it also includes barriers in a patient's life defined as their life context, so things like stressful events, perceived stress level, and functional capacity, really kind of the background noise. So we have the questions. How do we find the answers? We do that by the use of objective, standardized assessment instruments that can help us determine what factors may be at play in a patient's situation. So just to summarize this section, without reading through all of these, it's really important, though, that you see the impact of, the co-occurrence of chronic medical diseases and mental health diseases, and think about the impact of the mental health diseases on the chronic medical diseases. So assessing and progress monitoring of treatment, assessing for mental health conditions and progress monitoring of any treatment among those with chronic medical conditions becomes really critical in working to reduce the slide says depression, but clearly all of the mental health conditions, and then mitigating the negative effects of the mental health conditions and the biopsychosocial factors that are at play. So it's really important also to include evidence-based assessment as part of the process of implementing evidence-based practices in clinical settings. Getting a baseline evaluation and then ongoing progress monitoring are important components of this process. Both are very routine in other parts of healthcare, right? So the tools that we use to detect psychological disorders should be those then designed to inform us of the existence of a problem before we select the treatment, and then our instruments should inform the efficacy of our treatment. If we rely exclusively on interviews, that really leaves us prone to incomplete understandings and often bias. Psychological test validity is very strong and compelling, and it's comparable to medical test validity. So using assessments helps us reach the goal of providing evidence-based treatment, helps us determine the problem to be treated, how severe that problem is, and then as we provide care, we use assessments to help objectively determine the progress we're making. So the first results at the outset provide the baseline and an increase in our understanding of the concerns that the client brings to the office, and then the assessment tools help us clarify the diagnostic picture and monitor progress as well. So there's a lot of important considerations when selecting an instrument or instruments that are used in an assessment, including when assessing for mental health conditions. And so I want to talk about a few of those, things that help us choose an appropriate instrument, assess its quality, and then use it ethically. And note that I'm talking about objective tests, right? Tests that measure an individual's characteristics independent of rater bias or the examiner's own belief. So the objective of assessment in the healthcare setting, of psychological assessment, is to provide useful information regarding, again, the planning, the implementation, and evaluation. And so the most important factor in test selection is the extent to which the test is useful in answering the referral question, right? That's the most important thing. Beyond that, some of the considerations then are things like administration time, the time that it actually takes to administer the particular instrument. Clinicians in many settings need really brief, standardized tools that can be used as diagnostic aids. At times, you will also want a more comprehensive instrument that assesses broader aspects of a person's functioning and well-being, but that is definitely a consideration. Next is the language or languages in which the instrument is available, and also the languages in which the instrument has been validated for use. So sometimes you'll find an instrument that's been translated into another language, but the necessary validation studies may not have been conducted in that language. Another is administration options. Some measures are administered using paper and pencil and require time to score and then interpret. A lot of advances in technology recently have made it easy to develop programs that administer and score and even provide reports for clinicians to reduce the clinical burden and increase the standardization of the interpretation. So clinicians in clinics can use laptops or smartphones or tablets or kiosks to administer measures while clients wait for their appointments. Many tools are now available digitally, many as questionnaires that can even be emailed prior to an appointment. Another consideration would be scoring and reporting options. There have been some studies that have shown that clinicians report that barriers to the use of standardized tools include time demands and ease of administration and scoring. So, of course, scoring by hand remains an option for most instruments at this time, but it's time-consuming and it's more subject to human error than digital scoring options. Those are really increasing in availability. And then reporting options obviously still include manually written reports, but also various types of electronically produced reports, score reports, profile, interpretive, multi-rater reports, progress reports. This is a picture of a progress report here where you can see change over time. So the first two data points, here you go. this data point and this data point are both considered kind of baseline markers, and then in this particular assessment, there was the intervention date was entered to indicate when an intervention was begun, and then you can see change in symptomatology after that. You can see the lowering back into the normal range of symptoms. Being able to see that kind of progress graphically or in table format is super powerful and helpful in also, when being able to show that to a patient. So progress monitoring is really important, and it's becoming more widely used as digital tracking becomes available. Again, it's really powerful in being able to show that to a patient. Users of screening and assessment tools also need to assess the psychometric properties of tests that they intend to use and ensure that they meet the criteria for acceptable psychological tests given their intended purpose. Basic psychometric properties of tests to be evaluated include reliability, validity, classification accuracy, fairness, norms adequacy, that's whether or not the reference groups that are used to assist in test score interpretation adequately represent the population for which a test is designed. It's really important to clearly understand the population for which a particular test is intended. So norms enable one to make meaningful interpretations of obtained test scores, and they really should be based upon representative samples of individuals from that intended test population. So when you're selecting a test, you need to make sure that the norms actually cover the population for the patient that you're assessing. And then commercially prepared and published versus public domain instruments. Often one of the most important considerations there is also the availability of the normative information that I just mentioned. Another consideration is which informant should be used, whether or not you are assessing the actual person, a self-report, or whether you're assessing somebody by obtaining information from another person, so an other report, which provides the most rich data. For example, depression. The nature of depression, that is primarily an internal experience, so even though observers are able to make some observations externally, the richness of the data that you can get from self-report is distinctively different from that obtained from the report of others. Again, it's one of those considerations. So it's really important to note that the selection of appropriate tests requires that you understand the specific circumstances of the individual being assessed, because the importance of an accurate diagnosis is an implicit prerequisite to the selection of evidence-based tests, and the tests are largely organized by disorders or by maybe some of them are certainly more broadband. The diagnostic categories are the common language through which we think about and question and communicate findings, and especially in the healthcare setting where you're communicating with others about a person's conditions. So all these considerations are important when you're selecting instruments. You just want to be sure that there's data that support the use of a particular instrument. They really need to have strong psychometric properties and be appropriate for use in the population for which they're being used. So, as I mentioned earlier, psychological tests should have strong psychometric properties if you're going to use them, but scientific surveys looking at the science of psychometrics, the scientific surveys apply the science of psychometrics to the assessment of feelings of populations and predict behaviors, and standardized psychological tests apply the science of psychometrics to the assessment of the feelings of individuals and predict behavior. Looking at what can predict behavioral failure, you see medical tests predict medical aspects of outcome, psychological tests predict behavioral aspects of outcome. Dr. Karaji, a physician, studied patients who were undergoing lumbar discography. That's an injection technique that's used to evaluate patients with back pain who haven't been responsive to extensive, more conservative, non-surgical regimens. The most common use of discography is for surgical planning prior to a procedure called a lumbar fusion. But Dr. Karaji and his colleagues thought discography could predict who would go on to develop back pain. Some of the study participants had undergone cervical surgery or had been diagnosed with chronic pain syndrome, but none had lower back pain at the start of the study. But what they found was that patients with poor coping skills, as measured by psychological testing, or with chronic pain, were nearly 3 times more likely to develop back pain compared to those with neither. A history of disputed workers' compensation claims also was predictive of future back pain. But a crack in the disc or a high-intensity zone seen on the MRI was only weakly associated with back pain, and the results of that were not statistically significant. So Dr. Karaji said the structural problems were really overwhelmed by the psychosocial factors. So just a study that kind of drives that home. So when thinking about test selection, 2 seconds. Okay. When thinking about test selection, I want to point out that there is some overlap between things we would consider psychiatric tests and those that we would consider health psych tests, or those that are specifically to assess pain. And you can see here those areas of overlap. So psychiatric tests might assess for thought disorders, where pain or health psych tests assess for pain disorders. Psychiatric tests assess for mood disorders, pain or health psych tests assess for physical functioning, etc. So you see the differences. But then you can also see that there's overlap in that these, if they are standardized assessments, they have validity, and they are mostly going to assess for things like depression, anxiety, which really fits in both categories, and addiction. Those are probably the main areas of overlap. So thinking a little bit about selecting tests, or kind of about the point of, or the viewpoint of these tests, psychiatric tests have items that are really more specifically written to assess psychiatric patients, whereas most pain or health psych tests are written with items to assess medical patients. So again, you can see that there is just a little bit of a different viewpoint. There again is the overlap that I showed on the last page, and both of these types of tests are useful in the medical environment, especially if you consider how many different medical environments there really are. Okay, so just as an example, some of the maybe psychiatric tests that you might be thinking of would be things like the MMPI-2, the MMPI-2-RF, the MCMI-3, the PAI. Pain and health psych tests might include things like the MBMD, the BHI-2, the BBHI-2, the P3. I'm going to talk some about some of those toward the end, or show you a little more information about them, but just as an example of those categories. And it's important to note that they also differ then. So just as an example, using these two tests, the MBMD and the BHI as examples, the MBMD being the Millon Behavioral Medicine test, and the BHI, the Behavioral Health Inventory. So the BHI-2 test is designed to help identify the biopsychosocial factors that can interfere with the patient's normal course of recovery from an injury or chronic pain or illness. There's 2 sets of norms for the BHI-2, rehab and chronic pain patients as 1, and the community norms as 2. And there are 8 reference groups: chronic pain, headache and head injury, neck injury, back injury, upper extremity injury, lower extremity injury, fake good and fake bad. The MBMD test is a more personality and psychopathology-based test, written, of course, from Millon's personality theory. And it includes 3 norm group options. And it includes some areas that aren't covered by the BHI-2, including things like coping styles and stress moderators and treatment prognostics, as well as negative health habits such as smoking and lack of exercise and overeating. So again, and I'm going to talk more about both of these 2 instruments in a few minutes as well, but I just want to point out that, even within health psych instruments, they have some overlap, but they also have some differences. So the rule of thumb is basically always to select your tests based on what you want to know. Remember, select your tests in order to answer the referral question. So let's look at some examples now. I'm going to spend probably the last part of this just covering some of the examples that I've included in your handout. And you'll notice that in your handout, and what you're going to see here, is that for each one, I'm going to talk about it on one slide, but then there's a second slide, I'll show you here, that covers some of the details about the tests, such as the administration time, the age range, the languages, the administration options, and the scoring options, and maybe reporting options for those that have reports. And I'm not going to go over those, so I just have included them just for more detail. Screening for cognitive status, which is something that is done, should be done almost always in the healthcare environment as far as I'm concerned. But it certainly should be conducted on anyone with memory concerns or other cognitive complaints, or those with non-memory triggers like personality change or depression or deterioration of chronic disease without any explanation, those with falls or balance issues, or those whose caregivers or others close to them report cognitive impairment. And cognitive status screening is now being conducted on Medicare beneficiaries every year as part of their annual wellness visit. The purpose of screening for overall mental status is really to provide an estimate of the quality of clients' functioning, to determine the need for further testing, or to determine treatment needs, sometimes to determine progress or to assess progress when functioning has declined, especially in an emergency situation, or to periodically assess decline that may be more insidious, like in a dementia. The components of a mental status evaluation should really assess amnestic functions, cognitive processing, form and content of thought, looking for symptoms of psychopathology, just in an overall cognitive status eval. Because detecting possible cognitive impairment is really the first step in determining whether or not a person needs further cognitive evaluation. In a time-limited visit, which most of them are, many clinicians begin with a screening instrument such as this one, such as the brief cognitive status exam, and it's used to assess cognitive abilities really quickly and reliably, including in patients with dementia, mild mental retardation, traumatic brain injury, or even suspected Alzheimer's disease. It's a standalone version of the optional BCSE, which is found in the WIMS-4, so some of you may be familiar with it. It provides a really brief screen for significant cognitive problems. It identifies significant impairment even in low-functioning individuals. It's not diagnostic of a specific clinical disorder, but it would provide an indicator of current cognitive status, like average or low average. It actually classifies into 5 levels of functioning, and low and very low scores would suggest possible clinical issues and a need for further eval. But it assesses a variety of cognitive functions. The examinee performs simple tasks in a number of different areas, including orientation to time and mental control, clock drawing, incidental recall, automaticity and inhibitory control, and verbal production. And so, again, I'm not going to go over this next slide, but it's there for your reference and in your handout. The next group, though, is the BECK scales, which I know you should all be familiar with. I'm not going to go through this slide in detail either, but I just wanted to point out the BECK, the BDI, the BECK Depression Inventory, is the most used depression screening tool, and it includes the severity of depression as part of its assessment. So the BDI FAST screen reflects the cognitive and affective symptoms of depression. It's really a quick and effective way to quantify depression, but excluding symptoms that might be related to medical problems. So it was developed specifically for evaluating depression in patients whose behavioral and somatic symptoms that may be attributable to biological or medical or alcohol or substance use problems might confound the diagnosis. So it helps to screen with consideration for those. And then, of course, you screen for anxiety with the BECK Anxiety Inventory, which has been found to discriminate really well between anxious and non-anxious diagnostic groups in a variety of clinical populations. And then also the BECK scale for suicide ideation, which helps identify individuals at risk for suicide. It measures attitudes and behaviors related to suicidal ideation. So there are a number of other BECK scales as well. These are ones that I put here that are just frequently used in the medical setting. And they're quick, which, again, is an important point. And as you can see, these are all available in English and Spanish. Those also, let me go back to that slide for just 2 seconds, because these are all administered, except for the BDI FAST screen, can be administered digitally, which means that progress monitoring is also available digitally, which is super helpful in a medical setting. The battery for health improvement 2, which I went through a little bit ago, except I said behavioral instead of battery because sometimes I do that. The battery for health improvement 2 really presents a concise, coordinated assessment of those biopsychosocial issues that are most relevant when evaluating patients with injuries. It evaluates for those psychosocial and social factors that really often go undetected in situations like this, in a medical setting, but those that can significantly interfere with the patient's response to treatment. So you can see here the uses of it. And this, the BHI-2 has several report options that include one that provides information about medical intervention risk. So if the physician or surgeon is considering something like a surgical intervention, there's a report that can be obtained from this instrument that would give them information about the potential for treatment failure, really, the risk for treatment failure, depending on or attributable to a number of different factors that are evaluated in the BHI. Okay, again, just some more information about the BHI. The BBHI-2 is a briefer version of the BHI-2. It is a brief diagnostic tool that's really well suited for initial intake and outcomes measurement of patients who are treated for pain or injury. Again, it's derived from the widely used BHI, but it's shorter, and it helps practitioners really quickly evaluate for a number of psychomedical factors commonly seen in patients with injuries, things like pain, somatic and functional complaints, as well as the traditional psychological concerns such as depression, anxiety, and patient defensiveness. And again, here's the information, the briefer information about that one. The pain patient profile is used to quickly evaluate for depression, somatization, and anxiety in pain patients. It focuses on those factors that are really frequently associated with chronic pain. There's a lot of evidence that half of adults with anxiety or depression also report chronic pain, and so this test really can help provide an objective link between the physician's observations and the possible need for further psychological assessment. There's several good report options, and you can see that this test actually a number of these do come with a summary of the results that are useful for sharing with the patient. Several of them also come with a health provider report or summary that's useful when speaking with the physician. So it summarizes the information for them. So the P3, it looks at things like the patient's emotional readiness for an intervention maybe or surgery. It supports evaluations for cases that may involve vocational readiness or orthopedic or occupational or auto injuries, workers' comp, long-term disabilities. Easily is used to measure pre- and post-treatment pain status to evaluate whether or not a treatment has been effective and monitor progress or outcomes. It's also, again, pretty brief. So the scales here include depression, anxiety, somatization. There's a validity index. Let's see. So, again, the brief information about that one. And then the Millon Behavioral Medicine Diagnostic, which you may be familiar with. The MBMD helps provide a broad understanding of the psychosocial assets and liabilities that may affect an individual's response to treatment, helps to enable clinicians to really develop tailored treatment recommendations. It's pretty brief. It is comprehensive, though, and there are 3 norm groups, one that includes a comprehensive sample of patients with chronic medical conditions, one that's specific to bariatric surgery candidates, and one that's specific to patients with chronic pain. So psychologists, physicians, nurses, other healthcare providers use the MBMD results to help identify patients who may have significant psychiatric problems and recommend specific interventions, pinpoint personal and social assets that may facilitate adjustment to physical limitations or lifestyle changes, and determine whether patients need more communication and support in order to comply with prescribed medical regimens. So again, the briefer information about that. So let me go back to the MBMD really quickly. just to say that this one is one that has a one-page healthcare provider summary that is really useful when talking to the medical staff about the results. And then it has the choice of reports for specific population groups that I mentioned a minute ago: general medical, bariatrics, and pain. Because of the general medical normative sample, it really allows the MBMD to be extended into a variety of settings, medical settings, including things like sleep disorder centers or cancer treatment centers or cardiac rehab programs, military and veterans hospitals, primary care facilities, things like that. And on to the MMPI. Hold on one second. Here we go. The MMPI, as many of you know, the most widely used and widely researched test of adult psychopathology. And the MMPI-2-RF helps clinicians assess mental disorders, identify specific problem areas, and treatment planning in a variety of settings. So among the uses of the MMPI-2-RF, the ones that maybe are relevant to what we're talking about today are used in areas to assess major symptoms of psychopathology, personality characteristics, and behavioral proclivities. You can see on the slide many of the overall uses. It's also used to evaluate participants in substance abuse programs and select appropriate treatment approaches, and then to assess medical patients and design effective treatment strategies, including chronic pain management. And the reports here include a clinical interpretive, a new spine candidate, and stimulator candidate interpretive report as well. Here's the briefer information on the MMPI-2 and the MMPI-2-RF. And the next one I want to talk about is we call it the QOLI, the Quality of Life Inventory. It is to assess positive mental health and help guide clients to a happier life. It's pretty brief also. It's comprehensive, though. It assesses positive mental health, well-being, and happiness. It provides an overall score that's based on the Sweet 16 areas that are thought to make up quality of life, including things like love and work and play. So it's a measure of positive psychology, and it has a variety of uses and in a variety of settings, including medical. It's well suited for planning and evaluating and tracking medical and psychological treatment and patient progress. You can see the scales here that are measured in the table on the lower part. It identifies real life issues that helps clinicians develop treatment plans and predict future health problems. Kind of provides instead of looking, from maybe the things that are wrong, it provides a more positive mental health picture that helps increase the likelihood of successful treatment outcomes. And the progress report that is available helps to focally see outcomes measurement for interventions that are designed to either alleviate physical illness or psychological disorders. It really helps managed care providers kind of objectively demonstrate that their services have improved a patient's quality of life. And again, here's the briefer information about the QOLI. And then the Symptom Checklist-90-Revised, which some of you may be familiar with. The SCL-90R it's a multidimensional self-report inventory that's designed to help the provider screen for a broad range of psychological problems and symptoms of psychopathology. It's used by clinical psychologists, psychiatrists, counseling professionals in mental health, medical, and educational settings, as well as in research. It's useful in both the initial evaluation and for measuring progress. It's well researched. There's over 1,000 research studies now that demonstrate its reliability, validity, and utility. It is brief. It measures 9 primary symptom dimensions. It's designed to provide an overview of these symptoms and their intensity at a specific point in time. So it really helps then facilitate those treatment decisions and identify patients before problems become acute. So you see the scales, symptom scales there on the screen. It was normed on 4 groups: adult psychiatric outpatients, adult non-patients, adult psychiatric inpatients, and an adolescent non-patients. And here's the briefer version on this. And then here is the actual briefer version of the instrument itself, the BSI, which is a briefer version of the SCL-90R that measures psychological symptoms and levels of distress. Takes about 8 to 10 minutes. It really is designed to reflect psychological symptom patterns of psychiatric and medical patients. Again, it's the short form of the SCL-90R, but like the SCL-90R, it helps the clinician in an initial eval or for progress monitoring. And it's especially appropriate in clinical situations where debilitation may result in reduced attention and endurance, where you need a briefer version, or in outpatient clinics where testing procedures demand brevity. It's also used, again, for measuring progress. The scales and the norm groups are the same as the SCL-90R. And then I just want to talk about the ACEs again. It's just important to cover childhood trauma. We've learned a lot about the effects of adverse childhood experiences and other traumas, including that vast body of research that support the idea that trauma increases risk for chronic physical and mental health conditions that I mentioned earlier. So the Childhood Trauma Questionnaire is used to identify adolescent and adult clients who have histories of trauma in a valid and reliable way. And so I didn't want to leave it out. This questionnaire also includes a minimization or denial scale for detecting individuals who may be under-reporting traumatic events. And it also has some interpretive guidelines that help identify likely cases of abuse and neglect at different levels of severity. And the manual offers some advice about the clinical uses as well. Okay, and there's the briefer information about that. And so just to summarize, it's really important to include evidence-based assessments as part of the process of implementing evidence-based practices in clinical settings. You need to remember to select the tools based on what you want to know, answering the referral question. But baseline evaluation and ongoing progress monitoring are important components of the process that you use in the healthcare setting. They are routine in other areas of healthcare. So use of standardized tools prior to a treatment initiation for screening and diagnostic purposes will allow you to target treatment and identify appropriate interventions. And using standardized tools to monitor and evaluate treatment and to provide feedback over the course of treatment results in improved outcomes in medical settings. And again, excuse me, you want to make sure that you consider things like time to administer, your needs, the clinician's needs, but also whether or not the instrument is appropriate for and designed for the use in which you want to use it, and whether or not it's going to help you monitor progress, and most importantly, answer the question. So that is all the information that I have today. I want you to have my contact information. My email address is here. We have a website. PearsonClinical.com is, of course, our website, but we have a health psych page at this point where we've kind of focused some information on the area of health psychology and behavioral health, and some of the instruments that I mentioned are highlighted there as well. Please contact me if I can answer any questions or provide any help. Or, of course, contact customer service if you'd like. Thank you so much for attending today, for giving up your time, and I hope that this has been helpful. Please answer, if you have a second, please answer the survey that will appear at the end of this so that you can give us some feedback on other information that we can help provide to you or any changes that we can make in webinars. Thank you again.